Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Hey Turd Nerds, we are happy you're back because we are happy to be back. I have no idea what we're talking about today because Dr. Gurvich has a apparently pretty cool case to go over.
So I am a very big fan with seeing super complicated people that nobody else has been able to address or get better. Generally, by the time they come into me, they're probably 3 naturopaths deep, functional medicine doctor on the side. They started with their conventional, their primary, their this, the
international
nutritionist.
dietitian.
Yeah,
for
sure.
In Australia.
87 gastroenterologists.
They probably paid $10,000 for a program
Multiple
that taught you this or that.
scopes.
Yeah. So and then they walk into my office and I am their last hope, which I gotta say, no pressure. This is the reason why I love this case, and this is a case that I lecture about a lot actually. The reason that I love this case is because she literally had everything going on. Like, everything going on. So she came in and,
what are approximate demographics on this person?
So she was like 60s female, who came in with a primary complaint of diarrhea. Yeah. And actually, I believe that she, right before seeing me, she had her third scope, and one was a screening, and then they waited 5 years, and they redid another screening. She never had a polyp. Finally, after the third scope, she was like, can you just take some biopsies? Yep. And so they did a diagnostic scope, and the diagnosis that she had was
collagenous colitis?
Microscopic colitis. That was the diagnosis. And they had started her on budesonide 2 years before. So she had been taking budesonide every single day for 2 years. And I was like, well...
That's a long course of budesonide,
There's no data going longer than 6 months. Wow. And what happens when you take long-term budesonide is you start getting all of those, systemic corticosteroid side effects with this localized steroid. Yeah. So she had been on it for 2 years. It was not doing her any favors. She was still having 4 to 6 Bristol 7 bowel movements every single day.
And it was the right kind of budesonide that you had previously talked about.
It was
delayed release.
Delayed released. Yep. It dissolved into it was brand. It was brand.
The prescription one.
Yeah. It was a brand. There was no way to mess it up. The brand only does one thing.
Okay.
And so she came up, and she had actually come in with a stool test. So her first stool test that she had found.
This is like a specialty lab. This is
one of our functional GI labs.
Yeah.
This happens to be, she had a test for my favorite functional GI lab. There was no limitation of findings on this test. So
did you do a biofilm beforehand?
No.
You didn't even do your normal thing.
Came in,
okay.
She came in with this test.
All right.
So unprovoked stool test.
This is unprovoked. She was working with her local naturopath.
Okay.
That was probably naturopath number 3 for her. I was finally naturopath number 4. And I don't even know how she heard about me. I don't know. Maybe she watched like a forum or a webinar or whatever.
Or the Turd Nerds.
It was before our time. The Turd Nerds were not even. I don't even.
Maybe she found you. Maybe she looked you up and found your name just randomly in a directory.
Yeah, or maybe. Do you know that I have this patient?
Trouble. There's Dr.
I believe my brand.
No, you've had patients that liked your last name.
So my first patient ever, there was a moment in time when it was me and 2 other providers that were the only 3 naturopaths available on the entire Blue Cross website. Wow. And I was the only one with an ethnic, quote unquote, last name.
Wow.
And she is still my patient.
Wow.
She is still my patient.
Wow.
I was like, wow, what a crazy moment in time.
Totally.
Okay, so this patient came in with a stool test from a different provider, a functional PCR stool test, and she had... So, guys, this is when you take a nap because this list is so damn long.
Okay.
No.
She had cryptosporidium that was found on the test. She had
Giardia?
No, only crypto as far as frank parasites. She had protozoas, but that's coming later. As far as pathogens go, she had Bacillus, Enterococcus, Pseudomonas, Staph, Strep, Klebsiella, Citrobacter, and Mycobacterium tuberculosis. Mycobacterium avium.
So no big deal.
No big deal. Yep. Right, totally no big deal. Then... By the way, I'm not even at protozoa yet. She also came in with Blastocystis homini and Dientamoeba fragilis, 2 protozoa.
Do you think this was from the steroids?
Well, she was suppressed, right? So she's going to pick up the... Yeah. It's a good point.
It's a hard thing for me to say.
Yeah. We'll never know. But
I mean, I think she had... The reason why they started her on the steroids is because she had this problem before. Okay, so I'm not done. She also had her...
But it's a good connection that while you're immunosuppressed... you might pick up some more of these opportunistic pathogens.
Yes. Yeah, exactly. We also, they ran an elastase. That was actually within normal limits, but her steatocrit was a 27.
Wow.
Yeah, that is not the highest I've seen, but it's pretty up there.
That's pretty good.
Remember, this is unprovoked.
Yep.
Her elastase, her steatocrit was a 27. That's a fecal fat marker. Yep. That tells us how much fat is being absorbed. Not very much of her fat was being supported.
Was fine.
Elastase was normal.
Do you see that discrepancy frequently on your favorite
That is the way that I differentiate. Do I need to... If the elastase is low and the steatocrit is high, no brainer, start with PERT therapy. Start with pancreatic enzyme replacement therapy. That makes total sense.
Okay.
If the elastase is normal, but the steatocrit is high.
Yes.
So I'm going to give you guys a disclaimer, minute 6 into our episode, where I'm like, that was what I missed with her, is I didn't start with a steatocrit, but she had so many other things.
Mm-hmm. So what would you do in that, if you were going to do, so it's not specifically that there's low pancreatic enzymes, but maybe she needs some lipase, bile acid support?
I think she needs bile acid sequestrants. Mm-hmm. And that's like a done.
Bile acid sequestrants.
We'll get there. You guys are pulling out you're like fast forwarding me, and I want to go fast.
I thought you might give supplemental.
No, I would have started with bile acid just because you're going to get her feeling better, and I find you get better traction treating the microbiome if you get that inflammation from the malabsorption better.
I have to say
that's recent that we're all.
I have to say that in my perspective, I think I saw her in 2017, 2018. I started seeing her, and in my current 2024 perspective, I would agree with you.
Yeah.
Okay, but I didn't agree with you in my 2018 perspective.
Well, and we never learned any of that in school.
I have a question.
I'm ready.
So if you give a bile acid sequestrant, the steatocrit will go down in the stool, but is that helping her absorb fat?
So I guess I was so my perspective was she's on the steroid. She can't get off of it. It's not doing anything, but everybody's afraid to take her off of it. Mm-hmm. She has 1 parasite that we know causes diarrhea and 2 protozoa that we know cause diarrhea.
Protozoa.
Which parasite
Crypto
eats bile salts?
I don't know.
I never even heard any of that.
Yeah, no. I think...
some of them deconjugate. I think there's certain ones there's certain microorganism patterns that deconjugate bile salts. But I feel like, she's got 3 protozoa that all could be contributing to
Right. And crypto,
right, typical.
But here's the difference. Yeah. Crypto, it usually presents and spontaneously resolves. The body can generally
if you're
deal
immunocompetent.
With it. If you're immunocompetent. So I was like, oh, this is going to be the easiest case ever. No brainer. I am going to give her a bunch of anti-parasitic medications. Because she had the Blastocystis homini, which in my experience does very well with nitinoxanide or Alinea, and because she had Dientamoeba fragilis and crypto, I think I put her...
everything.
She had everything. So I think what I usually do in that situation is I'll put them on a longer course of nitinoxanide with 2 short spurts of Tinizol or Tindolmax.
Wow.
So that's what I did. I was like, dude, this is so easy, no brainer. Yep. And so what I did is I treated her parasites, right? And then she came back and I was like, oh, how are you doing? And she's
like, I have side effects and I hate you.
Well, she didn't have a lot of side effects from the drugs. She actually did great with the drugs.
Okay, maybe that was a case I had.
Because you went too aggressive?
Who knows, Alana?
Yeah, it's true.
Please proceed.
Okay, so, basically I think I got her to go from 5 to 7 bowel movements that are Bristol 7 a day to 4 to 6 Bristol 7 bowel movements a day, right? Wow. And this was to be honest, this is when I was just first starting to learn about microscopic colitis or collagenous colitis. And I went to a conference and I talked to, I think I've told this story before. I talked to Eric Yarnell. who's a big herbalist.
We give a lot of shout outs to him.
Yeah, I mean, he's an amazing, but I was like, how do I treat mycoscopic colitis? And he was like, parasites and food intolerances, right? And so then I treated her parasites. Well, that didn't work. And so then I was like, I don't get it. Maybe I didn't go aggressive enough with my anti-parasitic treatment. Can we rerun the GI map? So we came back and we reran the GI map, and it looked different. The crypto was gone. She did come up at this point with, the crypto was gone and the microbiome looked significantly different.
The bacterial marker.
The bacterial marker. The Pseudomonas was no longer present.
And this was provoked this
This
time?
was provoked,
okay.
Yep. The Pseudomonas was no longer present.
Do you think that was from the nitazoxanide? Or what do you think got the Pseudomonas?
I mean, I guess what I think is if you get rid of the parasites, then you just,
the way... the microbiome.
Yeah, I think of it as like, it's not like if you have a good neighborhood, it's a good neighborhood. Yeah. But if you have a couple of bad guys that are in your good neighborhood, it's not a big deal. Yeah. But if you have a bad neighborhood, it's a bad neighborhood. And if you take the bad guys out, you can make a good neighborhood. That's kind of how I think about it.
We once had a guy who was on America's Most Wanted down the street.
Did you?
Oh.
In your residency?
How'd you find out?
Well, Ken befriended them.
Wait, this is important.
That's for another day.
This is important?
I shouldn't be sharing. Please proceed again.
This is such a great story. I just want to say, I have known Dr. Kapadia for, at this point, 2 decades, right? I think I've known you for about 2 decades.
Were you afraid at night?
I was not living there at the time.
Wait, did you turn him in?
No, he was befriended. He was a protector of the neighborhood.
Wow.
That's a great story.
I'm going to ask Ken about it. I cannot wait.
Yes. This is juicy.
Okay, so back to my case. So crypto was gone. A bunch of my bacterial bad guys were gone. Pseudomonas was gone. Klebsiella was also improved. Those are my 2 bad guys. She still had Bacillus, Enterobacter, and Strep. I did have fungal markers start popping up at this point. So I didn't know to look at it at that point. And the Blasta was still there, and the Dientamoeba fragilis was there.
So I don't know that Dientamoeba usually responds to nitazoxanide, but it may.
But I had the tinidazole in there for it.
That's true.
And it does usually respond to tinidazole.
Or paromomycin, maybe?
I feel like if I don't get a response, tinidazole is just really easy to take.
Easier
really
to get to,
Yeah. So I usually start there. Tinidazole is... 2,000 milligrams once a day for 3 days. And I usually dose the day before, the day of, and the day after a full and a new moon. And so that was better. Her elastase still looked beautiful at 520. And her steatocrit was a 14. So the ranges in my lab that we use, cutoff is 15 or under. I want to see it at not detectable. It will become not detectable if it's 7 or lower. Yeah. Anything over 15 is flagged. So technically that steatocrit wasn't flagged.
Yeah, but reference ranges, like we could have a whole episode on that. Don't trust reference ranges.
Yeah, I mean we could have a whole season on that.
Especially steatocrit, right? Because it's a one-time marker. We're not doing a 24 hours.
Yeah. Oh my God,
fat
that is so unfair.
Yeah, that one's awful.
That one's truly awful. And then, the other thing that was high, actually, hold on, let me see. Yeah, what I did not mention actually last time is the secretory IgA and the anti-gliadin were elevated in both tests.
So you tested her celiac?
I'm
or
sure.
She was scoped.
I feel like she actually had been gluten-free for years and years.
Still, you gotta know.
I know, but I'm not going to tell her. Yeah.
But if she had an endoscopy, they would have seen.
They would have done biopsies.
So then I was like, okay, well, obviously what I did didn't work for the parasites, right? And obviously what I did didn't work for the parasites. So I think I probably changed my course at this point. And then I think I asked Dr. Kapadia, what do you usually do
for those bugs?
For those bugs. And so I gave her the paromycin, which is a milligram per kilogram dosing, but I can never remember what it is off the top of my head.
People can look it up. It's standard. I think it was 500 TID or something like that.
Yeah, or 750 TID.
Yeah.
Yeah. So I tried that. And I went after food allergies. So my favorite test is like the hokiest test out there.
Maybe you shouldn't share this.
Yeah, I run an old naturopathic test for food allergies.
It is hokey. It's
really hokey. I still swear that that's how I control my Crohn's, but. So we pulled out those food allergies. So retreating for parasites, and I think that this time I also tried to put in anti-parasitic herbs, right? Okay. So retreating for parasites, pulling out the food allergies. Probably I got like maybe another 15%. So maybe she was having 3 to 5 bowel movements a day that were still Bristol 7, as opposed to, you know.
And she's still on budesonide?
She's still on budesonide.
Wow.
And so then I went back and I was having a conversation with one of my colleagues in that magical room where all the magic happens for clinical thinking that this entire podcast was based on. And somebody started talking about bile acids. And I pulled up her labs and I was like, that damn steatocrit.
Yeah.
I have been focusing on parasites. Yeah. And ironically, we were up and doing this episode, and Dr. Sam was like, can we just do one on parasites?
Yeah.
And so...
Which we will. We'll get there, but...
But you know what it was? It was the steatocrit. And so then I started doing a deep dive on bile acid malabsorption. This is the case that got me looking at bile acid malabsorption.
Yep.
So then I found the bile acid sequestrants, and we started her on them, and within a week... she was having 1 Bristol 4 bowel movement a day.
It's a home run.
Like within a week. It was kind of crazy.
Yeah.
It was crazy. And so we were able to get her controlled. And once I had her controlled for about 2 or 3 months, I was like, dude, budesonide's not doing anything.
Yeah.
Right? So then I pulled away the budesonide. It was doing something. Oh, no. She got a little bit more loose.
Okay.
But it wasn't like...
Did you up the cholestyramine then?
We tried to up the cholestyramine. We tried to do this balancing act.
Yeah.
And the reality is, I think that the steatocrit being elevated and the bile acid malabsorption was like 85% of the picture.
Yeah.
But it wasn't like, and she was better, you know what I mean? And she could take the stupid powder, but it's a little bit, it's annoying to travel with. It's a lot of space. Like she was like enjoying her retirement. She wanted to travel. Yeah. And so then we tried to play around. And actually what we ended up doing with her is I started being like, I wonder, since you're so chronic, if there's a biofilm picture here. Right. And so then I put her on, I don't actually think I put her on the Bistiol complex. I think I just put her on bismuth. And I gave her 750 milligrams of bismuth with a cholestyramine, and that is where she stayed for the next 3 years, having 1 to 2 bowel movements, 2 packets of cholestyramine.
You kept her on the bismuth that long?
Because she would come off of it, come off it, come on. And so I'm actually in process with her right now, because the problem with bismuth is there's data that says it's good for 6 weeks.
Yep.
But in the
toxicity,
if you use it for a long amount of time,
mineral depletion.
If you use it for a long amount of time, there could be a toxicity with it. But she didn't want to get off of it, and every time I'd be like, "Let's pull you off," and then she'd flare again. Let's pull you off, and then the cholestyramine is like, obviously the cholestyramine is holding the floodgates together.
Yep.
But like with a rubber band, there's a lot of leakage that's happening.
Have you tried subbing the Dr. Sam's favorite psyllium product with the cholestyramine?
I mean, how long have we been doing the podcast? Obviously, I have. I mean, this woman's desperate.
Charcoal, like she's tried all the other things with the cholestyramine. All the other
things. Yep. And so where I am right now is I took her off of the bismuth because I'm like, I'm concerned. Yeah. And she's like, psyllium and cholestyramine is not working. Yeah. And so I think I'm going to try her on mesalamine next.
Wow. Okay.
Because I do have a couple of microscopic colitis patients that do very, very well with mesalamine.
As a general anti-inflammatory.
Yeah.
What about the data on mesalamine with turmeric? Do you do that?
I've tried it. I'm not going to say I've ever seen any magic.
Yeah.
I've also seen mesalamine with probiotics. High-dose probiotics have good data on it. Well, I want to say good. There's like a 20 or 25-person human trial that shows relatively good efficacy, but anybody who reads data knows that if it looks good preliminary, that doesn't mean it's going to hold water.
Totally. And probiotics especially. Be skeptical.
And just to review, when you did the whole talk on bile acid malabsorption, there's not a great test that we have for it, so we go by steatocrit or qualitative fecal fat. So
let me just response to sequestrants.
Right. So let me give you a quick reminder of that in case or you can go back and listen to our bile acid malabsorption episode, which I think is number 3 out of our list.
Wow.
Yeah, I know it's not as big as constipation.
Yeah.
America is constipated.
Did she have her gallbladder, this patient?
She had her gallbladder.
Okay. I was going to ask that. Yeah. Great.
So when we're looking at bile acid malabsorption testing, there's the option that's only available in Europe. In Europe, the option is they give you a meal with a bunch of radioactive bile salts, or radio-labeled, not radioactive, radio-labeled bile salts.
Wow.
They take a picture, an x-ray. They take an x-ray. After you eat the meal, they have a count of how many particles are in there. They have you come back 3 days later. Most of those bile salts should be still in there if it's not bile acid malabsorption, and they should be gone if it is bile acid malabsorption, right? Because that means it's not being resorbed.
Why don't we do it?
Because of, I think, safety because the problem is, let's say if they have diarrhea.
Giving people radiation here, though.
That's true. It's the radio labeled.
Especially if you go to the ER.
Right.
Don't go to the ER with abdominal pain unless you really need to go to the ER with abdominal pain.
Okay, so that's what you do in Europe to see if you have bile acid malabsorption. You look at how many of the bile acids are being resorbed, right? If you go, the only blood test that we have in the U.S. is looking at conjugated versus unconjugated bile salts. The problem with that one is it's only catching roughly 25% of the people who can present with bile acid malabsorption, right? So that one doesn't work great. Then we've got the fecal fat markers. One of the fecal fat markers is we give them this high fat diet, and then we collect all of their stool for 3 days.
Keep it in the fridge.
Disgusting.
Keep it in the fridge. These people cannot leave the house.
That's traumatic.
And then they give them to a lab tech. You know, he's the like
who
that's the hero of my story.
Know exactly what to look at because they only get this test once every 20 years.
Right, totally. And somebody gives them 2 jugs of poop, basically. They have to like carrying it like 2 suitcases. You know what I mean?
So we do a qualitative.
So that's a quantiitative.
Right.
Then there's the qualitative, which is just a random sample.
Right.
Yeah.
Which is steatocrit is also that, but the steatocrit is a steatification of the fat to give you and it's actually for bile acid malabsorption something like 93% predictive.
Yeah.
There's a lot of data on it.
Steatocrit.
I'm confused why it's not in modern medicine.
Why it's not part of the testing algorithm.
Yeah, I'm very confused about that.
I think because bile acid malabsorption isn't on people's radar.
It's not on the full radar, especially.
No. Yeah,
so this person did not have cholecystectomy, so something is deconjugating her bile acids.
Her microbiome was whacked.
Yeah.
The other thing that she has, which is very predictable, is severe osteoporosis.
From the collagen, microscopic colitis.
-4.
Oh.
Very severe. Right? So with this patient, I kept her on cholestyramine. It held it together. We added bismuth. It was amazing. She was so stabilized.
Yeah.
But every time I took her off, it wasn't doing anything. I think
if you dose it with minerals, not at the same time, but is it safer long term to be on bismuth?
I mean, I think it just can be neurotoxic long term.
Yeah.
And I don't know
in part due to the mineral depletion.
Is it neurotoxicity?
I thought it was just, or it's some sort of. I could be totally wrong. I just thought there was some sort of toxicity that was.
There is a toxicity, and I believe it's kidney.
It can mimic. No, it can cause neurological issues too. Long term, it can almost like mimic MS.
That seems right, actually.
Yeah. Yeah, I know.
It would depend how much of it you're absorbing as opposed to like pooping out, right? So I don't know if there's a good way to monitor. I don't know of any way to monitor if it's going to potentially cause a problem for someone.
Yeah.
Yeah, and that's the problem is, it is one of these things that has been around forever. Mm-hmm. Like Chinese medicine texts, Ayurvedic texts, but
not for long term generally.
You think that they weren't using it in ancient China long term? I'm not sure about that.
I don't know. I'd have to call someone.
Yeah, my answer is I would think that they were.
Huh.
Okay, toxicity. So symptoms include delirium, psychosis, ataxia, myoclonus, seizures, and kidney damage.
Yeah.
Yeah, so neurology, you're right.
And stuff you don't want.
Yeah, totally.
Just a general list of things.
And generally, if you discontinue it, this kind of stuff will turn around, minus the kidney damage, even though the kidneys just don't heal very well.
No.
So that is where I am with her. And I think I just literally messaged her this week saying, hey, if I can't get you off the bismuth and everything's bad, I need to see you more often again.
Right.
Like I'm missing something.
Yeah.
And I think that really what that might look like is me rerunning that stool test to see maybe she has such poor immunity.
Yeah.
Right.
Maybe the parasites were part of it.
And you don't think hydrogen sulfide SIBO.
That's why I think I started her on the bismuth to start with.
Yeah. And oregano?
I am sure that I did a hydrogen sulfide protocol with her,
Sure.
Maybe doing the more aggressive biofilm treatment.
I'm thinking I have to change
after targeting the whatever now is showing up on her stool test.
But I think I need to re-look at her stool.
Interestingly, the 3 types of diarrhea that Dr. Gurevich kind of taught everyone about over the last few years at some of the conferences, EPI, bile acid malabsorption, and microscopic colitis. And she's got 2. I don't know that I would have thought to look for bile acid malabsorption in someone with microscopic colitis.
I wanted to bring that up because 100% of my patients right now with microscopic colitis respond to cholestyramine.
Yes. And I mean, I think I showed you guys, I have...
But that doesn't necessarily mean they have bile acid malabsorption, because cholestyramine used to just be used for diarrhea too, right? So But it is interesting.
So, guys, I have this data set that I think I've shared with all of you guys, but this is just a very simple chart of what are the drugs that we use for microscopic colitis. And loperamide, obviously, bismuth, mesalamine, cholestyramine, budesonide, prednisone, azithromycin, and azathioprine 6-MP, and methotrexate. That is the order of prescriptions that they have according to this chart.
Yeah. And she's been on loperamide, I'm assuming.
Oh, she started with loperamide, like everybody does. So then loperamide,
can you combine it with?
You sure can, but loperamide is very effective initially and loses traction the longer and more consistently you use it.
I didn't know that.
Yeah, you totally have to. You have to be part of a rotation.
But bismuth doesn't.
Bismuth doesn't, but then you have the toxicity with it. You know what I mean? Like that, there is like not a sweet spot. And I like, you know, at this point she's like late 60s, early. She might be in her 70s. Like I am not sure I'm not going to be able to change her microbiome that drastically.
So I know we can't tell any of this, but do you think it's due to inflammation, dysbiosis, malabsorption, or just like all of it?
Yes. Yes. Yes, I think it's due to all of it. I think that she started out probably with like a little bit of dysbiosis that got worse, got worse. She you know, by their 60s, she's having a lifetime of like dysbiotic stuff. You know what I mean?
Yep.
Like I think it's all of it.
Yep. I did find Giardia.
Oh, isn't that interesting?
Takes up conjugated bile salts in the ileum. So yeah, I heard that somewhere, but that there's a correlation between at least Giardia eating your bile salts.
So interesting.
Weird and gross.
Yeah.
And that would result in
malabsorption.
But not necessarily related to bile acid malabsorption because it's consuming it.
I mean, I don't know. You're not emulsifying fats properly.
Yeah. Interesting.
Yeah.
Yeah, I mean, it is... She is very complicated still. Like, I'm still knee deep in it. And I've been at it since, like, we're almost at a decade.
Yeah. I think microscopic colitis is a bigger clinical challenge for me right now than anything else. I think we have a lot more tools at our disposal than maybe their conventional docs are using with them. And, like, it's a hard one.
Yeah.
The diarrhea is hard. And no one's getting diagnosed. Like, people...
Still.
Listen to our episode on microscopic colitis.
Right.
But... I mean, a lot of people, I'm like, ugh.
And even when you send them for a diagnosis, they're not even diagnosing. Exactly. They're like, oh, this is a screening. This is a screening.
Yeah. Exactly.
No, it's a diagnostic.
Yep. Yeah, I have a whole template on my patients where they're like in their 60s, 70s. Because the mean age of diagnosis is 65,
That sounds right, yeah.
Women who are 65. Yeah, and I'm like, tell your doctor, have it in the note when you're going under for the colonoscopy. Your last
hold up a sign. Hold up a sign.
Your last request is please, dear God, biopsy
before the propofol.
Yes,
that is so unfair.
And what's the
necessary?
Yes.
And maybe like make a sign on your abdomen.
Oh, good. Or on your butt.
Or on your butt.
With a Sharpie.
You know, now they do it when they label the leg. You're gonna
reminder.
Amazing.
So that was my case. If anybody has any ideas, I'd love to know it. But sometimes it's more than one thing.
What a gut.
Thanks for the case.
What a gut. What a podcast. Thanks, everyone.
Bye. Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.